Welcome to this Clinical Explainer. Today, we're diving straight into clinical rounds, focusing on breast pathology and management. Here's our agenda for today. 1. Benign presentations and cysts. 2. Cytology and diagnostic biopsy. 3. Axillary staging and surgery. And finally, 4. Advanced disease and complications. All right, let's jump right into Phase 1, benign presentations and cysts. So our first question, a 4-year-old girl presents with a firm left breast mass and a family history of breast cancer. What's the next step? Is it A, immediate excisional biopsy, B, a mammogram, C, repeat examination in 1 month, D, genetic testing, or E, stereotactic needle biopsy? The correct answer here is C, repeat the examination in 1 month. Conservative observation is absolutely mandatory here. We're almost certainly looking at an asymmetric early breast bud. You've got to avoid any surgical intervention or needle biopsy to prevent permanent mammary hypoplasia. Really crucial point there. Moving on. A 29-year-old female presents with a cystic lesion 4 centimeters from the areola. The FNAC is negative for malignant cells. What's the next best step? A, repeat FNAC in 6 months. B, repeat mammogram in 6 months. C, repeat ultrasound in 6 months. D, excisional biopsy, or E, no further action needed. And the answer is E, no further action needed. If you have a solitary benign cyst that completely resolves upon needle aspiration, meaning it yields non-bloody fluid and leaves absolutely no solid mass, it requires no further surgical intervention. You simply reassure and discharge. Next question. We have a 29-year-old female presenting with a 2-centimeter cystic mass. FNAC shows non-malignant cells. Next step. A, excisional biopsy. B, repeat aspiration. C, wide local excision. D, ultrasound after 6 months. Or E, no further intervention at the moment. The correct answer is E, no further intervention at the moment. If that cyst collapses fully and leaves a flat tissue bed, an ultrasound confirmation is totally sufficient. This is a great way to minimize unnecessary surgical biopsies. Okay, slightly different scenario. A 29-year-old female has a cystic mass. The FNAC is non-malignant, but this time, the cyst recurs. What is the next step? A, excisional biopsy. B, repeated aspiration. C, wide local excision. D, core biopsy. Or E, none of the above. The correct choice is B, repeated aspiration. It's actually completely safe and appropriate to try repeated needle aspiration, just as long as the cyst retains smooth, benign features on ultrasound and that fluid remains non-hemorrhagic. Let's summarize this with the definitive clearance rule for managing simple breast cysts. If you get non-bloody fluid and the lump completely resolves, that equals reassurance and discharge. Simple as that. However, if that fluid is blood-stained, if there is a rapid refill, or if a solid mass persists, you need to escalate to a core biopsy or excision. And as we just saw, recurrent but smooth cysts, just repeat the aspiration. Let's move smoothly into Phase 2, cytology and diagnostic biopsy. Question. A 32-year-old female has a 2 by 2 centimeter mass. Fine needle aspiration shows atypical cells. What is the diagnostic category? A, C1, B, C2, C, C3, D, C4, or E, C5? The correct answer is C, C3. Whenever you see cellular atypia that is likely benign but just lacks the definitive diagnostic metrics for malignancy, it correctly falls right into the C3 category. To put that in context, let's look at the entire breast cytological grading framework. C1 means the sample is inadequate. C2 is definitively benign. C3 is atypical but probably benign. C4 is suspicious. And C5 is definitively malignant. The big takeaway here, a C3 or C4 score cannot guide definitive therapy. It absolutely mandates a follow-up core needle biopsy. Next up, a patient presents with discomfort in the right breast, but there's no palpable lump. A mammogram shows microcalcifications. What's the next best step? A, reassurance. B, MRI bilateral breast. Or C, US-guided core biopsy. The correct answer is C, US-guided core biopsy. Because we literally can't feel a lump, ultrasound provides the real-time needle visualization we need to accurately target those non-palpable, distinct hypoechoic structures. Moving right along to Phase 3, axillary staging and surgery. Here we go. A 37-year-old has a core biopsy showing ductal carcinoma. When exactly is a sentinel lymph node biopsy indicated? A. Bone scan suspicious. B. Positive pregnancy test. C. Palpable axillary nodes. Or D. Desires partial mastectomy. The correct answer is D. Desires partial mastectomy. Basically, a sentinel lymph node biopsy is the standard of care for clinically node-negative axillae, especially when doing breast-conserving surgery. Similarly, a 36-year-old undergoes breast conservation surgery for stage 1 breast carcinoma. What is the management of the axillary lymph nodes? A. No need of assessment. B. Sentinel lymph node biopsy. C. Level 1 ALND. D. Level 2 ALND. Or E. Level 3 ALND. The correct answer is B. Sentinel lymph node biopsy. Again, breast-conserving therapy for early-stage cancer absolutely requires accurate staging via a sentinel lymph node biopsy. We want to avoid any unnecessary extensive axillary dissections if we can. Let's quickly review the axillary anatomical level mapping, which relies entirely on the pectoralis minor muscle. Level 1 is lateral to the muscle. Level 2 is deep or posterior to it. And level 3 is medial to the pectoralis minor, extending all the way up to Halsted's ligament. Next case. A 38-year-old has a true-cut biopsy showing ductal carcinoma in situ, or DCIS. What is the appropriate treatment? A. Breast conservation surgery with radiotherapy. B. Chemotherapy. C. Breast conservation surgery with chemotherapy. Or D. Breast conservation surgery with chemoradiotherapy. The correct answer is A. Breast conservation surgery with radiotherapy. Since DCS is strictly non-invasive, systemic chemotherapy actually plays no role here. But adjuvant radiation is incredibly important to reduce the risk of local recurrence. Now, a middle-aged female presents with stage 1A invasive breast carcinoma. That's T1, N0, M0. Most appropriate treatment. A. Radiotherapy. B. Breast conservation surgery, axillary staging, and radiotherapy. C. Radical mastectomy. D. Modified radical mastectomy with axillary staging. Or E. Chemotherapy. The answer is B. Breast conservation surgery, axillary staging, and radiotherapy. It's pretty amazing, but this multimodal strategy yields long-term survival rates that are totally equivalent to a full radical mastectomy. I want to quickly highlight this distinction because confusing DCIS and LCIS is a huge clinical pitfall. DCIS is a true premalignant proliferation, and it's treated with local excision. On the flip side, lobular carcinoma in situ, or LCIS, is basically a non-surgical indicator of bilateral risk, and we manage that via observation. Huge difference. All right, final section. Phase 4. Advanced disease and complications. Question. A 38-year-old with stage 2A disease presents with a 4 by 5 centimeter mass. What is the best cosmetic treatment? A. Radical total mastectomy. B. Modified radical mastectomy. C. Partial mastectomy. D. Skin-sparing mastectomy with implant. Or E. Skin-sparing mastectomy with tram flap. The correct answer is E. Skin-sparing mastectomy with tram flap. When the tumor-to-breast ratio is this large, using an autologous tram flap yields far superior, natural-feeling aesthetic outcomes compared to using implants. Next, a 44-year-old presents with stage 3B breast cancer. Appropriate treatment. A. Modified radical mastectomy. B. Neoadjuvant chemotherapy. Then modified radical mastectomy and post-op radiotherapy. C. Total radical mastectomy. Or D. Chemoradiotherapy. The correct option is B. Neoadjuvant chemotherapy, followed by a modified radical mastectomy and post-op radiotherapy. For locally advanced disease like this, you absolutely have to use systemic therapy upfront to shrink the local tumor burden. It literally converts an inoperable lesion into an operable target. Let's test some pathology. In which of these conditions is alkaline phosphatase raised? A. Osteoporosis. B. Metastatic breast cancer. C. Osteopetrosis. Or D. Hypervitaminosis. The correct answer is B. Metastatic breast cancer. Why? Well, advanced breast cancer often tracks hematogeneously straight to the skeletal system. The resulting osteoblastic repair response distinctly elevates your serum alkaline phosphatase levels. Our last case. A patient is 10 years post-mastectomy with chronic lymphedema and is now presenting with bluish-red skin nodules. Best treatment? A. Observation. B. Excisional biopsy. C. WLE plus radiotherapy. D. WLE plus chemotherapy. Or E. Amputation. The correct, albeit difficult answer is E. Amputation. This presentation is classic for Stewart-Treves syndrome, which is an aggressive angiosarcoma. Because the cancer spreads so diffusely along the lymphatic planes, radical amputation is sadly the only viable option here. So, as we wrap up this explainer, I'll leave you with this final thought to ponder. Have targeted conservative treatments like sentinel lymph node biopsies and active observation permanently redefined the boundaries of surgical morbidity?